day already, and this draws now to a conclusion of your day and not to further work or study that you may encounter. So I want to talk to you about the work that we've been doing in my laboratory and in our centers on generative artificial intelligence. I will explain what that is and how we can use it towards thinking about health in a more holistic way. And maybe we should start with a brief first step, namely the realization that data saves lives. And that realization is actually not a new realization. In fact, John Snow, the father of modern epidemiology, already effectively invented data science when he tried to manage the cholera pandemic in London. And so what you're seeing here is a map of London. And that's actually the map that John Snow drew. So you see every single street in central London where the pandemic was. And he invented another thing that is called the bar chart. And as you can see here, along the streets, you will see black rectangles that are the higher, the more patients diagnosed with cholera were found in each individual house. You have a visual depiction of the density of cholera cases. And he had a hypothesis that cholera was spread through water, and specifically water pumps that had sources of infection. And so then he drew next to it into this painting the water pumps. And he found that basically there was a single water pump that was at the center of all cholera cases in the surroundings. And so effectively he did a first causal manipulation. He had the water pump shut down by the city authorities. And after the water pump was shut down, in fact, the cholera epidemic was stopped because the cases rapidly decreased. So this is a very fruitful application of data science in the most classic of senses. He invented visualization, did causal manipulations of the causes, and was able to establish the importance of water as a source of infection for cholera. And so this beautiful thing, you can still see the original water pump in Broad Street in London if you go and visit, is a beautiful illustration of how data can save lives. And so when we're thinking about data, we should think about how we can make use of this data. So in the classic days, we said we can do data analysis or statistics, but over the years, other methods arose, and we call them artificial intelligence methods. And these are mainly methods that are driven by the idea that machines can learn from data to solve a problem for which humans need intelligence. So artificial intelligence. And this idea that it's not a human that builds or programs the solution, but instead that a human builds a machine that learns, and then the machine learns from data how to solve the problem, is probably the biggest shift in innovation that humanity experienced since we learned how to make fire. Because for the first time, it's not a human building the solution, or developing or inventing the solution. It's a machine discovering the solution. And so to speak, human computer scientists, human AI researchers are more like parents that teach children how to learn, and then the children, the machines, learn to do things. So this is a very simplified way of describing the relationship between AI, machine learning, and data. Now, when we're talking specifically about data, AI and machine learning in healthcare, we need to be aware of what the setting is. And of course, you are all in healthcare aligned degree courses and professions. And so the idea here is really that we have a rapid rise in the demand for clinical health and care. And there's simply a lot of unmet demand. That's because society has become increasingly older with an explosion of cases that require health and care. We have pandemics, we have climate change that leads to new diseases or growth of diseases such as lung diseases, for example. And simply we have a dwindling workforce. There are not enough nurses, carers, and doctors that can treat patients. And so the idea of our field in AI for healthcare is to help to reduce the unmet demand for health and care by using machines, AI systems that basically take and offload routine demand and routine cases from carers and doctors. And so I've used the term generative AI. What do I mean by that? Well, most people will know something that we call analytical AI. So it's an AI system that can recognize my face, for example, if you just show it enough cases. And if you use Instagram, Facebook, or other technologies, then you will have encountered these methods already easily. Now, analytical AI can only recognize things, it can analyze the data. Now, that in contrasts with what we call generative AI, where you can ask the AI not just who is this, but you can also say, oh, create me a picture of somebody with black hair and in black glasses. Create a picture of this person, and you create a whole artificial face of a person. That's generative AI. So these are systems that only understand the data, but have a sufficient understanding of the data to create new data. And so a classic example here is, for example, create a photograph of the Pope in a white snow coat. And although our Pope never wore these clothes, you get a life picture of him. So this is the power of generative AI, that it can create answers that it has never seen before, examples that it was never given before. And along this axis, analytical generative AI, we have another axis that is perpendicular, and that's the axis between perceptual artificial intelligence and cognitive artificial intelligence. And so perceptual artificial intelligence is artificial intelligence that imitates our human perceptual abilities. If you do an auscultation with a stethoscope, for example, you use your hearing ability to perceive if the lung is, for example, free, or if there is something going on in your lungs. If you are a radiologist, you may look at a scan of a brain to determine if there's a brain tumor, for example. So these are perceptual abilities, and they are mainly used in diagnostics. And we contrast that with cognitive artificial intelligence, where it's not just about recognizing a pattern, performing a diagnosis in that sense, but really steering, for example, a ship from New York to Hong Kong, and making many decisions on the way. Note, the captain may not do all the actions himself or herself. The captain will instruct other people to do things. And that's, of course, very similar to how we're thinking about therapy in medicine, because you have interactions with a patient. They follow your instructions or not, and this will change how their disease presents itself, how they're presenting themselves, and there's an interaction loop going on. So you need to plan, manage, and adjust. And that is a more cognitive requirement. It's not just about examining a patient, but it's also about understanding how to treat them. So let's talk about generative AI. Of course, the most famous examples of that is ChatGPT. I think, I hope all of you have already played with it or used it. And over the past year, I think the development was very, very dramatic. So in 2022, we had the privilege to play with ChatGPT 3.5, and you could give the old version of ChatGPT, so to speak, various American high school exams, advanced placement exams. So this is, if you take that exam and pass it, you can skip the first year of college for that program specifically, and it could pass roughly half of the advanced placement courses. Now, the exciting thing is, once we had ChatGPT 4 roughly a year ago coming onto the market, it could pass the vast majority of advanced placement exams. And there are examples, for example, of how ChatGPT passed also, for example, the German or the Bavarian Abitur, the final year exam in the European system as well. And similarly, people applied ChatGPT, for example, to medical licensing exam questions, and the system seemed to perform well on these questions. Now, what is this ChatGPT? Well, first of all, it's what we call a large language model. It's a language model because it's trained on human text or human language, and we assume that ChatGPT has been effectively trained on all text available on the internet in total, and specifically all English text. And what does this model do? Well, all that it learns, all that it can do is predict the next word. So, for example, if you give the text "thou shall not," then the system will predict, out of all the words it knows, what is the next word. Probably if you know the Bible, you know the sentence "thou shalt not kill." Less often you may have seen the word laugh or run, thou shalt not laugh. Maybe you've heard occasionally, thou shalt not steal. And so out of all the text that the system has seen, it only that it simply does is predicts the next word. And so all the interaction that you're seeing with ChatGPT, where you type text and it talks back to you, all that it does, it generates simply the next word based on all the words that you spoke with it before, including your words that you entered into the system and what ChatGPT answered. And that's surprisingly powerful if you have enough training data, as we have seen. Now, the interesting thing is ChatGPT is more than just a next word predictor. So large language models have two components. The other component is that you need to teach the system what are meaningful and non-meaningful answers, right? So what you do here is you ask the system a question and it gives you a number of answers. And then you need humans that go and look at these answers and tell the system, this is a sensible answer, this is a nonsensical answer, this is an inappropriate answer. We all have heard the cases where ChatGPT said illegal or wrong things that it shouldn't have said. And basically, it's about a bit like training a parent, training a child of what is allowed to say, what's not right to say, whether things make sense or not. And this is very labor intensive. And again, in the case of ChatGPT, people assume it took roughly 1 million hours of paid human interaction to teach AI systems good manners. And for cost reasons, these were maybe not done with the most educated people in California, but probably with people who are willing to work for minimum wage. We know also that a lot of this work has been carried out, for example, in Africa. So you have now systems that are taught by humans what is right and wrong, but we don't fully understand who trained them and what values these people had who trained them and what answers were given. Anyway, once you have this, what we call rules of what you should and should not do, and from that, we can then train an LLM to give answers. Now, that is basically what a large language model is. And so we were then curious to see, could it pass some more advanced medical exam? And specifically, we wanted an exam where it's not about, what's the name of the artery that branches off from the aorta in that location. We wanted sort of reasoning. We wanted to see how good is it actually at medical skills, not medical facts. And so we took the UK neurosurgery examination, which has 500 questions, and ChatGPT did not pass the exam. It failed. It performed very well on neuroanatomy anatomy and pharmacology, where basically just memorized a lot of facts, but it was very poor in making complex judgments or planning settings. And so without going into the detail, we gave it questions like this, where patient presented itself and it needed to make an assessment of what to do. And in this case, the system completely failed at doing the right things, and in fact, followed a path of inquiry that would have delayed the right care for the patient. So we need to be very careful when we're looking at such systems. Now, why am I talking about ChatGPT? Well, because we've been working on generative AI for the past 15 years, but we have not been working on text. We've been working on medical data that was not text-based. And I'm going to show you some example of how these systems look like when you don't apply them to text, but to actual clinical data. And just to give you an example of the setting that we're working with, so we've set up or helped set up the whole systems integrated care Discover Now hub in Northwest London that comprises roughly 2.3 million patients. These are all general practitioners, so all primary care doctors are plugged into this, and all 6 hospitals in Northwest London are plugged into this. And we have linked all the data of all the patients, so we know how a patient goes from the doctor to the pharmacy, to the hospital, back to the doctor, back to the pharmacy. We have the entire trajectory for years on end of data. And for example, then you can do simple things like, for example, we have here a list of all the anonymized, in this case, patients that have asthma. We can visualize now how this patient is doing. We can link this now with where their address is. We don't see the address, but the system knows the address and can correlate that with pollution and climate data, for example, when there are high ozone levels or high nitric oxide levels from car pollution, traffic jams, or other things, and can basically start thinking about making personalized recommendations if a patient should go out of the house or stay at home for their specific location in their typical surroundings and environment. So that's what we can do with data nowadays. Now it's about putting some intelligence in data. So let's look a bit at a challenge of what we call perceptual artificial intelligence. So I gave the radiologist examples, but perceptual intelligence is also understanding spoken words, for example. And that's typically where you have data from patient equipment, environmental information, or a business setting that gives you information that then a decision maker, an operator, needs to translate into an action. Yeah? What is the state of this patient? How sick are they? What disease do they have? And what I wanted to show you here is the many quick wins that artificial intelligence in healthcare achieved over the past 5 to 10 years in this domain. So here you see a list of different diagnoses. You see here in the next column the number of patients that this data system was trained on. And then in the next column, you see what we call the area under the curve, AUC. That's basically a number that if it's 0, then the system gets everything wrong. And if it's 100, the system gets everything right. Now, the interesting thing about these numbers is that they're not very high. For example, detecting sepsis has 85% correct. Detecting dementia has 90% correct. What does 90% mean? Well, that means that in 9 out of 10 cases, the system performs a correct diagnosis, and in 1 out of 10 cases, it's incorrect. For other things like sepsis in general, you have a 66% chance or 67% chance, which is 2 out of 3 patients are correctly diagnosed, 1 out of 3 are incorrectly diagnosed. Now, what's interesting about these papers here, that these are all papers that have above human performance in the AI diagnostic capability. So this means although these numbers are not very high by some standards, they're actually above that of expert human clinicians making the same diagnostic decision, which means that the human performance numbers are lower. And that's worth appreciating because, for example, when we're talking about self-driving cars, then we expect that a self-driving car can at least drive as many kilometers as a human driver without accident. And actually, the standards in industry are that we need to be able to drive 1,000 times as far as a human driver without accident to consider self-driving cars technology safe. In medicine, it's very different. It's a much more complex setting than understanding what to do on the road. Disease presentations can be ambiguous. Inter-individual variability can be very large, and very often our diagnostic methods are in themselves not particularly advanced. And so I want to give you an example from neurology, where we've been working on for many years, and where you're having a lot of diagnostics and monitoring in neurological cases that are done through human observation. That's also true for mental health and psychiatry. You interact and you observe by eye how a patient is doing. You're assessing how good a physiotherapy rehabilitates a stroke patient, how severe Parkinson's is, mostly by visual observation. And crucially, in all these cases, you as a patient are compared to the average patient. And this is again informed typically from studies that carried many patients, many of which do not have other conditions. Because you wanted to have a clean natural history, but many patients have other conditions. So patients who have stroke may also have diabetes or heart conditions and so forth. So you have a mixture of presentations and still you're simply compared to average. The hope is that AI technologies allow us now to compare you to yourself and to sort of see, for example, if your disease has progressed or not. And that's very important in the case of drug developments. So let's talk for a second about drug and treatment development in general. There are several problems. So the next generation of drugs that is currently being developed costs on average $2.6 billion to take a candidate molecule all the way to market. We have very long R&D cycles, takes typically 10 years to go from molecule to treatment that patients can ingest. We have an overall failure rate of 96, 95%. So only 1 in 20 molecules make it through to treatment. And we have very poor efficacy. So we have leading drugs that only work on 30 to 50% of patients. We have over 9,000 so-called rare diseases that have no effective treatment. And that makes drug development very risky, slow, and expensive. And so this becomes now very important when you're developing a drug that you can actually determine whether the drug is working or not. And I'm showing you here the anatomy of a drug trial. Again, this is average data taken from Nature Biotechnology in this reference that I will show later, where you're going through 3 phases of drug development. And typically only 70% of candidate molecules make it to phase 2, a third to phase 3, and a quarter out of phase 3 into approval and then pharmacovigilance. So that means that you have a rapid decrease in the number of candidate treatments. And so you better can determine very accurately how well a patient is doing. But if we're now looking at methods here that are purely diagnostic, so whether a patient is sick or not, you can imagine how much harder and how much imprecise it is to distinguish how sick a patient is and whether they've gotten 5 or 10% sicker or not. And so here, digital biomarkers have been making a promise. So digital biomarkers are biomarkers that are computed from the data exhaust of devices, be that wearables, implantables, or ingestibles. And the idea is that we have a facilitated validation of clinical effectiveness of so-called digital biomarkers, because you don't need to collect a blood sample. You can just look again at the data that you collected historically from the patient. And the idea is that because it's digital, you have an objective, repeatable measurement process compared to a human that observes you by eye. The problem is, however, that most digital biomarkers have very poor evidence. Only 12% of currently proposed digital biomarkers had their clinical effectiveness evaluated. A third of the biomarkers have been published in journals with no impact factors. So this means, you pay, you get published, basically. And of those that were published in journals with an impact factor, 93% were in impact factors lower than 5. So there's basically a fundamental lack of underpinning principal approaches and evaluation of these digital biomarkers. And so this has led us to formulate a project that we call the Human Ethome Project. I'm going to explain in a second what it means. That basically wants to replace these very partially old-fashioned biomarkers by biomarkers that have been extracted from human behavior. And I want to show you an example of that. So look at this set of dots that move. Okay, your brain, of course, you're very good at interpreting other humans' behavior. You see here a man or a woman walking. Let's look at another person. Let's look at this person here. This person seems to be probably relaxed and in a good mood, potentially. And we can look at another set of dot that moves. And here probably you have a person that is not in a good mood, low pose, low energy, probably maybe even depressed. So just from a set of dots, you with your human eye can already diagnose things or assign state of the patient. And the idea was, well, how good are we actually doing that? And so roughly 15 years ago, we started with a set of experiments where we simply measured the natural statistics of human behavior. So for example, if you open your textbooks, that would tell you the 2 most important hand movements are the precision pincer grasp and the power grasp. Now, the precision pincer grip is a very special grip. Your prosthetic hand can do that if you lose your hand. You're rehabbed on this if you had a stroke. And your hand surgeon will try to reconstruct your hands after an accident so that you can perform this. What we then did, however, is we asked, who says that these are the most important hand movements? And you find that it was actually some country doctor in England 300 years ago who wrote an essay and said, these are the most important hand movements self-evidently. So we're now living in the day and age of DNA sequencing, but we had no data backup for actual human hand movement. So we started basically putting here on grad students these digital data gloves that measured all the movements of their hands and asked students simply to spend the entire day from the morning to the evening wearing these gloves. And so to speak, we collected then the natural statistics of movement. And from that, we could then determine that virtually uh, no hand movements involved a precision pincer grip. Yeah, some used a tripod grip when you used a pen or a pencil, but no one used a precision pincer grip. And so we're really now living in the day and age of, as I said, genomics, proteomics, and large-scale connectomics, where we're measuring brain connectivity patterns, but we're still doing behavior studies at the level of the 19th century. And so what we called for is a program that's called ethomics, etho from ethology, the study of behavior, and taking a systematics omics approach to that. And so what we built over the years is a range of setups, effectively labs where we get people to live, flats. And you're seeing here two flats that we have currently in Kulmbach in Oberfranken, where you have people who can move in and live, and we collect every single movement of their body, every single movement of their fingers, where they're looking. So this is an eye tracking dog that tells you where they're exactly looking, and we can reconstruct their pose. And so from that, we can then do the hardest thing in medicine, start defining what is healthy, right? And then once you have a decent definition of what is healthy, then you can start defining what is unhealthy behavior, what is behavior that is indicative of disease. And basically, the story goes roughly like this. Imagine you have a human defined scale and you have patients who are sick, we draw them in red, and patients who are healthy, we draw them in blue. And you project them onto the scale, and you do that by eye observation because that's the standard in neurology. And then you have, of course, some human interpretation error, and it's not easy to distinguish the red from the blue ones. Good. Then you say, okay, let's use digital markers instead. So let's count the number of steps with a digital device. Let's see how people are moving digitally. And so you reduce the error in what you're measuring. And so you have a precise measurement on that scale. But still, you notice that you cannot distinguish perfectly the red from the blue ones. And that's, of course, also one of the reasons why when I earlier said that AI systems can beat human decision makers, it's not because the human decision makers are not great decision makers, but what they're basing the decision on is not very good. So, for example, if your biomarker is how many meters can you walk in 6 minutes, which is a standard assessment, the so-called 6-minute walk test, it may not be good enough to distinguish good patients that have progressed in the disease from patients who have not progressed in the disease. So now we built an AI, a generative AI, that learns from the behavioral data to distinguish healthy from sick people in a better scale. So now note how I'm not going to move the red dots and the blue dots. So that's where the patient's disease is. I'm just projecting these onto a different axis. So this is the human-defined axis that allows us not so good to distinguish the red and the blue ones. And I asked the AI simply to find a better scale that measures the progression of the disease for the same patients. And in this case, you can see, as I'm switching to this new scale, that the blue ones, first of all healthy people fall together in a narrow range because that's the healthy range. And then patients of different disease state are neatly segregated along the line further away from the blue healthy cases. And so this is a very successful approach that we have then applied. We call it jokingly behavior GPT because we started doing this before ChatGPT became famous. But effectively, it's a technology that reads behavioral data like ChatGPT reads English text. And here you're seeing now a boy that suffers from Duchenne muscular dystrophy. And so that's a terminal disease. It's a rare disease. It's a genetic disease. There's no disease-modifying treatment for it. And you see this boy basically performing, one of the standard clinical assessments in Duchenne muscular dystrophy, standing on one leg, and somebody measures with a stopwatch how long he can stand on one leg. You can, of course, imagine that if they have a good day, they do much better. If you offer them an ice cream afterwards, they do even better. And so there's a lot of confounders here. So what we're doing is we're digitizing the movements of that boy. We're then piping it through a system that looks a bit like a large language model, only just for behavior, that then allows us to map the disease state of the boy onto a scale. Now, that's for a clinical assessment. But again, we wanted to build a general system that understands behavior. So we have then used the data that we collected from all the healthy people to build a system, just like ChatGPT learned from English text how to read and interpret text, to read and interpret behavior. So now we have the same boy playing in their playroom, doing whatever they want to do. And the system can, again, using exactly the same pipeline, then now start diagnosing the state of the disease. And in fact, that works so well that we can beat the gold standard methods for assessing disease progression by having twice the precision. So we're twice as precise in measuring how each individual boy is doing. And more importantly, from a drug development perspective, while you need, in the case of the 6-minute walk test, you need roughly 60 children for an FDA-approved drug trial to validate a treatment that may or may not work on Duchenne. You need to have at least 60 patients, and you need a measurement precision of 55 meters. So you need to be able to say whether the cohort of kids that are under a new drug treatment can retain 55 meters of walking distance over 6 minutes. So this means that instead of walking 450 meters from taking the drug, they can walk 500 meters after 6 minutes. And in case of our behavioral biomarker, that is not even collected in the clinic. You can collect it wherever they do, wherever they go. We can do that with just 9 children. So you can have a much smaller drug trial. And we can do that in roughly half the amount of time because we have the same precision as the conventional 6-minute walk test has after 12 months, we have after 6 months. So we can shrink the size of the trial and we can shrink the duration of the trial. And we showed that for every single key primary endpoint that was developed for drug development in Duchenne. So that's nice, and that's for a very specific disease. Now, the interesting thing is we can apply that same system to other diseases. So we have other diseases that, for example, are epigenetic in nature. So these are diseases where the expression of a protein is dysregulated. And so there's not a gene missing, but basically the expression of proteins is messed up. And we focus on a specific disease. It's called Friedreich's that dysregulates a protein called frataxin. You can measure frataxin level from blood. And basically this leads to a movement disorder. So these are diseases that present typically themselves at 20 to 40 years of age. And of course, we could also then run the same method here on adults. And here you're seeing behavioral data from adults living in a living lab that we set up. And what we were then able to do here is not only reconstruct and basically reproduce very similar results to those that I showed you for the children in Duchenne, but we could do something that we call behavioral transcriptomics. Namely, what we had available, we had the actual gene expression rate. So how much of the protein was being made in patients at different moments in time of the trial. So every 6 months, we measured their protein expression levels. And using our atomic approach, we could reconstruct the rate of gene expression. So you see that the data lies on a diagonal. So this means that the measured level of the protein and our predicted level of the protein are highly correlated. Well, again, if you use the FDA-approved gold standard biomarkers that are based on simplistic assessments of human behavior, that there's in fact no correlation with the gene activity. So this means that that the approved gold standard measures for identifying patient progression cannot capture the genetic nature of this entirely genetic disease. Well, we can now basically reconstruct the level of gene expression purely from behavioral data, no blood samples required. And that's why we call the whole approach behavioral transcriptomics. And so we published this result in Nature Medicine last year, together with another Nature Medicine paper that describes how we can do next generation of diagnostics where the AI discovered the biomarker, not the human guessing that 6-minute walking is a good assessment of disease state. So I've spoken now about perceptual AI. Let's talk about cognitive AI. So once you have diagnosed a patient, you need to treat them. And so to treat them, you need to plan, manage, and adjust. And there's many decisions necessary. And of course, decisions that you as a carer are taking are affecting the trajectory of the patient downwards. And so now you have a loop of interaction where actions have consequences. You need to make many decisions. It's a bit like a ship captain or a surgeon or the British butler who knows what you need before you say it. And so in medicine, we now speak about digital therapeutics or the digital interventions, or how we call it, AI clinicians. So these are systems that treat patients. And so typically, we use here algorithms that take an action, observe the impact on the environment, in this case, a patient, and then observe whether the state of the patient has changed and whether some target quantity, for example, the blood pressure of the patient or some other thing, has been improved. And so basically, from this loop of interaction, the system hopes to learn how to treat patients. Now, we've done this for many years now. We started many years ago in diabetes and insulin, where we built an artificial pancreas algorithm that learned from interaction for each individual patient how much insulin to dose to ensure that you have a good glycemic level. And the system learned to deliver via implantable pumps the amount of insulin you should inject, personalized to each patient. In this system, we have tried indeed and developed in closed loop, but not in humans, in mice, and we then gave this method to Fresenius, who now hold the patent on it and can develop devices with that. The same approach we used for the dosage of anesthetics in surgery. Here we did not use a human trial. Here we built a simulation system that simulated the patient's responses to delivery of propofol, and basically we then used a measure of brain activity to determine how deep the patient is under or not, and that also allowed us to find a different strategy for dosing these drugs as the patient is under. Now, these methods were all developed in closed loop. So we intervened on the patient, and these are systems that are very well known. We know how tissue, propofol, and brain response react, so we can model that with equations. We also have even FDA-approved simulators of the glucose insulin response. So you can do that all in a computer in silico before you take it into an animal model and then to the human. However, there are many cases where the disease is very complex and we don't know how to even model that appropriately. And so we focused on sepsis. So sepsis is, of course, a systemic infection. It's the primary killer in intensive care. It's the it's the third largest cause of death it's the largest cause of death in hospitals. And we had pre-pandemic 31 million cases of sepsis per year, 19 million were severe, and 5 million people died from sepsis. So the challenge is sepsis is an infection, so you can treat it with antibiotics. The problem is your cardiovascular system collapses before the antibiotics can do the work. So now you need to think about, how do I maintain the cardiovascular operation of the body while the antibiotics do their work? And basically that relies on dosing and working with two type of interventions. One is how many IV fluids, how much volume you pump into the system, the cardiovascular system, and the other is how much vasopressors. So these are drugs that constrict the blood vessels and increase blood pressure in that way. And so there's a trade-off how you want to apply these. And so we wanted simply to know is, how clear is the decision-making strategy in the human expert decision maker? And so here you see the case where we picked 30 patients out of a patient database and showed their entire trajectory to 40 NHS consultants in intensive care. So these are expert intensive care specialized, and ask them what would you dose in terms of IV fluids and vasopressor dosage. And so basically you show the patient the history, you show them what drug they're on, and then you ask what drugs and what dosage they're on, and then you ask what would you prescribe. And what you're seeing here is the range of prescriptions, which sometimes spans 500% or more uh, across the population of 40 doctors, whether they would prescribe something or not, or in what dosage they would prescribe. Now, clearly, we all know some of these prescriptions are going to be much better than the others. No one can exactly say which are better or not. And so the AI clinician. And so what the AI clinician does, it's a system that continuously monitors the patient. And then at any given moment in time decides, oh, we need to keep the IV doses the same, or 5 minutes later determines we need to increase the IV dosage or do nothing or reduce the vasopressor dosage and so forth. So it's a continuous clinical decision system that continuously makes recommendations. And we could show then in a retrospective study that we also published in Nature Medicine in 2019 and 2018 that if doctors' prescription matched that what the AI clinician would have prescribed, so in a retrospective analysis, that then the mortality of the patient would have been lowest. And then came the pandemic, and we were one of the very few research groups in the world that worked on AI for intensive care. And so the entire program expanded. In the UK, we had severe problems with intensive care units. So the UK has a third of the number of beds of most European countries per capita for intensive care. So there was a severe shortage of intensive care doctors. So this has now grown to an entire program that we're developing where this AI clinician is now deployed in 4 hospitals in London, and we're evaluating it. So how does the system work? Well, it's again a generative AI system. And you can imagine what we're doing here is, and apologize for the gamification for explanation purposes, what we're doing here is we're trying to work out how to play this game so that a patient who falls sick or will be discharged and survive 90 days post-discharge from ICU and doesn't die in ICU. And so as a human player, you can of course see, oh, it's very easy. If you're here, you need to go up and then right and then right and then right. Or if you're starting the bottom right, you go left, up, right. Now that's obvious to you because you see the game board. The trick for the AI is now to work out what are the fields in this game, and that you have to do by analyzing and understanding the data of the state of the patients that you get from intensive care. So these are over 60 numbers, blood tests, blood pressure, heart rate, ventilator settings, and so forth that are incorporated here. And then you need to work out what combination and dosage of drugs corresponds to what movement of the error. And so this way, the system can then basically map this game field out and then work out what the optimal sequence of actions for a patient in every given state is. And that's difficult to visualize, but I'm going to try. So we have developed a visualization for this technology, where you're now, for example, seeing a patient. And what you're seeing here is a landscape of disease. So blue means high mortality, red means low mortality. And basically, we're trying to climb out of a valley of death. So look at patient B, you start in the valley of death, and then doctors make a decision. So they prescribe a drug, so that corresponds to an arrow going in a certain direction. The patient moves, not always exactly following what the doctors hope were happening, and so the patient's charts the trajectory in this case is discharged and survives. And you can see here from the arrows we've visualized how the doctor's decisions were pulling the patient in different direction, gradually marching them out of the valley of death to successful discharge. Now, the interesting thing is we can use this as a training tool because clinicians can now play with the system and ask, oh, what happens to the patient if? We can use it as a decision support system. For example, when there are not enough doctors, it's a night shift, it's a weekend shift, and nurses need to know what to do. They can get a recommendation, a doctor can quickly check them and then prescribe. Now, the interesting thing that we found is what happens when you open the hood on this. So first of all, what are the decisions of human clinicians based on? So if a clinician decides, let's prescribe this drug with that dosage, we can look at all decisions that clinicians made and try to work out what were the parameters, the physiological parameters. So for example, you see here the PF ratio is particularly high. For other diseases, for other factors, for other parameters, it's not so high. What's interesting here is that the AI clinician looks at other factors with more importance and looks overall at more numbers in a balanced way. For the prescription of vasopressors, it's even more dramatic, where it looks like human clinicians are only applying their decision basing on 4 numbers, the ones that you find in the medical textbooks, while the AI systems makes recommendations that are based on more than 12 to 16 numbers. So this gives you an impression of how such a system that learns purely from data how to treat patients, it knows nothing about medicine or pharmacology, can use, if you have sufficient large numbers of data, learn strategies that may not be visible to a human. And we've used this system now in 4 intensive care units. And basically, we're now approaching a state where we can start talking about high performance medicine. So the AI clinician system that I just spoke about was trained on over 65,000 patients. And just to give you a comparison to that, a senior intensive care expert who retires will have seen in their lifetime 6,000 to 8,000 patients. So this is 10 times the lifetime experience of a single doctor that the AI clinician can ingest. And of course, the more data is digitized, the more operational data we have from hospitals, the more the system can learn. And so what we're now really starting to talk about is a loop that we call the high performance medicine loop, where you have AI systems that can provide next generation data-derived monitoring diagnosis, give us higher precision, and we can talk about AI systems that can give better and more precise ways of intervening. And I've spoken specifically about these 4 papers that we published over the last few years. So with that, I really want to come to an end. There's a lot more to talk about. When we're talking about AI, in medicine, we need to talk about trust, interpretability, privacy, how we make it work in safety critical systems and in human-like systems. And just to give you a taste of that is what we've set up is now a simulation room in St. Mary's intensive care ward. So this is a camera that an actual intensive care doctor wears when they're interacting with our AI system. And for illustration purposes, it's not a real patient, but a clinical training dummy that you see, but the system is the same. So doctor comes in, looks at the patient chart, does the examination, sees the vital signs, and then in this case, what we've done is we've then shown them the AI clinician. The AI clinician is nothing else but a monitor saying, you should prescribe these drugs, and these are 4 different explanations why this is the right thing. And then the nurse asks, doctor, what's your prescription? Are you concerned about the prescription? Are you concerned about the AI recommendation versus your recommendation, and so forth? And would you stop the AI from operating? And the doctor leaves. Now, that's our trial that we've been running. Now, the interesting thing is, what I didn't tell you is that we run an eye tracker. So this is actually the eye movements of the doctor. And these colorful things that you're seeing are basically heat maps that tell you where exactly the doctor is looking at any given moment. What is he or she paying attention to? And one of the most striking things that we found is that the human decision maker did not care about the explanation. In fact, we found there was no correlation between what doctors reported was the reason why they ignored or followed the AI recommendation and the explanation that the AI gave, although they reported that there was a strong relationship between the 2 things. And so with that, I basically want to come to an end of my presentation. So I think in the future, we're going to see what we call AI-driven learning healthcare systems. I showed you the AI clinician loop that operates in the hospital. I showed you diagnostics and monitoring that can also operate at home, monitoring you personally. So we can call that the public digital health loop. And we need to think about how connecting these 2 loops. So basically, every single patient has a Sherpa, a digital Sherpa that guides them and watches over their health so that prevention at home, diagnostics and monitoring at home, and treatment at home and in the clinic are ideally integrated and not depend on having the right doctor, the right family member caring for each individual patient. And with that, I want to come to an end. I give the talks, but these are the wonderful people in the laboratory that have done most of the work. And I want to thank you for your attention.